All righty. Let's try this one more time. Okay, fluency. Module 5 this week. So what I do want to say is fluency is one of our harder disorders to treat. And I think there are a lot of therapists that aren't confident in treating fluency. And it's also usually one that kind of can be real severe and then really level off and then kind of revisit itself. So I do think fluency is challenging because it's something that we kind of usually have to check on and maybe do some therapy periodically, not necessarily long term. So, or can be, not always, but we can be. So fluency. So there's some definitions there. Definitely look at that because, like I said, speech likes a million words for the same thing. So if you hear disfluency or stuttering, usually speaking when a speech pathologist uses it, we're using those words interchangeably. Now, other educators may use fluency in a different way. So FYI. So developmental stuttering, usually, like I said, the books, and it can vary a little bit, but like 3 to 6 years of age. So that's kind of that developmental window, 6 being and older, but again, depending on if a child's had delayed language, usually what we see is developmental stuttering coming in later. So it's a bigger window than sometimes you'll read. A lot of times they'll say 2 to 5. 3 to 6, I feel like is the good range for developmental stuttering. And it usually lasts just less than 6 months. Occasionally we'll see it last a little bit longer, but you usually don't. And then we usually see whole word repetitions and no physical symptoms. So when I say whole word repetitions, I'm talking about repeating words, or sometimes what we see too is we see their language really improving and expanding, and it's like they can't quite organize it well yet. So neurogenic stuttering, let's talk about that. A lot of times we see that when we're looking at someone who's had a stroke, some type of head trauma. Excuse me, sorry, I have the hiccups. I apologize for that. An ischemic attack. So that's where they didn't necessarily have a full-on stroke, but they had some kind of attack where there was obstruction of blood flow in the brain. Tumors, cysts, or neoplasms, so some kind of growth. And then degenerative diseases. So definitely we see stuttering, and a lot of times stuttering is that first indicator that something's not quite right. So Parkinson's, MS, definitely we see it, ALS, and then other things like meningitis, Guillain-Barré, AIDS. So definitely some of those diseases where we see some of that neurogenic component come in from stuttering, and drug-related causes. So this is not just prescriptions and meds, this can also be illicit drugs too. I do want to kind of put that out there too. Definitely we noticed some differences with this particular kid we all knew, and all of a sudden he definitely had some stuttering and some weird stuff. Well, come to find out, you know, he was definitely severely abusing drugs. So anytime someone starts stuttering out of the blue, especially they're not in that developmental window, we should pay attention and look at that. So causes of stuttering. So let me just say this too. There is no one known cause of stuttering. Now, in neurogenic cases, we can kind of pinpoint what started the stuttering, but there's usually 4 factors that contribute to stuttering. So it's not a cause, it's usually kind of what I would call an influencer. So there's something that happened that influenced stuttering to occur. So genetics, development, so other speech and language problems, other developmental delays, we definitely kind of see that increase there. And that makes sense to me because their language is delayed. And then, or there's some kind of hiccup in the development. So sometimes I feel like we see stuttering with some kids that have kind of complicated medical involvement of various levels. So either chronic or maybe some severe medical intervention, neurophysiology. So definitely we see a lot of changes, and now with all these fancy MRI scans and all this stuff, we're really kind of looking at this. So anything related to our neurology definitely can impact and be a factor in stuttering. And also family dynamics. So when we say that, can a mother make a child stutter? Okay. What we can say is, I don't think anybody makes anybody do anything. But if a child already has difficulties processing language or organizing their language, and then you put other external demands like a family dynamic, like maybe a parent, but that could be really in any situation, they can have, that can definitely impact and influence stuttering to occur, you know, more often or on a regular basis, or where it wouldn't in another situation, but it's constantly occurring then. So stuttering is not just what I would call situational. So I tend to always stutter on office hours. I would never characterize myself as someone who stutters. And I wouldn't also say that I would identify as someone who stutters because I stutter on office hours. Usually I'm trying to like pay attention, see if somebody wrote something, you know, make sure I'm talking to you what I want to be talking to you about. So, you know, like I said, it's some dynamic that happens that causes me to stutter. But really what we see, it may occur when a combination of these factors come together, and it has different kind of what etiologies for different people. And we don't want to ever say there's one known cause. So we've not proven that. There's no scientific evidence. We just know there's factors that influence stuttering. So how many people stutter? More than 70 million people worldwide stutter. So that's a lot. The ratio of males to females. So this is what we know. And this is true for a lot of the disorders that we work with. Ratio to males to females is much, much, much higher. And approximately 5% of all children go through a period of stuttering. And if you've had kids on your own or worked with kids and you've kind of been in that developmental window, you would see it. So, you know, it's pretty common and it's not usually anything to be alarmed about. And then, is stuttering caused by emotional or psychological problems? So what I want to say is that children and adults who stutter are no more likely to have psychological or emotional problems than children and adults who do not. Okay, and there's no reason to believe that emotional trauma causes stuttering. What I want to say about that, like I said, that's kind of a loaded thing. Do people with anxiety stutter? Sure. When we look at someone who maybe has, you know, who panics. So if someone's going to panic, they're likely going to stutter because they can't get their airflow. Is that a stuttering problem, or is it more about an anxiety issue? So when we look at kind of etiology of things, we have to be sure we're kind of addressing what is the main thing, is just situational. So there's lots of common myths about stuttering. So now, people stutter because they are nervous. So because fluent speakers occasionally stutter when they're nervous, under stress, some people assume that people who stutter do so for the same reason. So while people who stutter may be nervous because they stutter, nervousness is not always the cause. Now, can you stutter when you're nervous? Yes, but is that the disorder? No. Do you have, are any of us 100% fluent? No. Can you stutter when you're nervous? Yes. So like, that's the thing. If you only stutter when you're nervous, you don't have a stuttering issue. I hope everyone's following this, because I feel like sometimes we talk in circles with this. And it's it's definitely, you know, there's a lot of other, what I would call cultural factors there when we talk about stuttering, you know, and then there's these other things about being shy. Um, so we really want to be sure sometimes that we're not dealing as a speech pathologist trying to diagnose a stuttering issue. If it's only occurring in one area or at one particular time, typically if we're going to diagnose somebody with a stuttering issue, it should occur across many situations. So it should occur at home, at school, at work, in public, in private. So definitely some of these things. So common thing. There was a student I saw, a high schooler. I thought when I first met him, he had a severe stuttering problem. That was my first impression of him. And I talked to his mom. His mom's like, no, he never stutters. I was like, whoa, okay. Big difference between school and home. And then looking at what maybe the issue may be, well, he had some extreme social anxiety. I saw the symptom of that, which I thought stuttering, but stuttering never occurred when he was with his friends, when he was at home, when he was in a situation, he had a job, he didn't stutter at work. Okay, well, then that's not a stuttering issue. So definitely as your supervisor will tease that out. Um, and what we want to say too is that there's a lot of different factors and we shouldn't be just dismissive. And myself as an SLP, like for that particular person, we had a lot of talk with some other professionals to support that person because his communication wasn't being impacted. So with stuttering, a lot of times too, you can go through all these myths. So prognosis. So every case is individual and depends on the response to therapy. Now, we also want to say is stuttering can dramatically impact someone's self-esteem. So a lot of times we need to be conscious of how are we impacting this person's self-esteem, because there are plenty of people that stutter and it doesn't bother them. And then we call attention to it and then something can change and shift as far as their mindset goes. So there's a fine line sometimes with what do we want to do to support somebody, what's necessary to support somebody, and that can be on a case-by-case basis. So for instance, I can share I had a high school student. I thought he had a pretty significant stuttering issue. We worked on it. He knew the strategies. He could use the strategies, usually, not always. And he was just like, I don't think I need to be here. Like, I've had this, my dad does this, my brother does this is just how we are. And when talking with him and his parents, I'm like, yeah, we don't need to, if he's okay with himself and he can communicate well, then he's learned to live with the stuttering that he demonstrates on a regular basis. So again, I feel like therapy sometimes for fluency can be very complicated and not just cut and dry. Hey, you have an issue, let's address it directly. So fluency modification. Now, there's kind of approaches to treating stuttering. So we kind of go back through some of these kind of components that can influence and impact someone who stutters. These review the stuttering. So a lot of what we see is part word repetitions, whole word repetitions, sound repetitions. So hesitations. Someone asked about that. What's the difference between that and a block? So a block usually is there's no sound coming out. Like they can't, so they'll be one who, here, let me stop the share. Usually when we see a block, hopefully everyone can see me. When we see a block, it's like you'll see their face, you'll see tightness in their mouth, their chin, and it's usually they'll be trying to say, let's say they're gonna say, you know, I am walking to my car, but they can't get the I out. You'll see, like they'll be saying, and then they finally will go, I am walking to my car. A lot of times, and they like spit it out real fast, especially after a block. So it's like it's almost like they can't get their voice out. It's like their voice is gone. So that's more of a block versus a hesitation. So a hesitation, and again, some of this can look specific to the client a little bit. So a hesitation's where the sound starts to come out like ah. It might be more of a sound repetition. Usually it's more than just one, syllable. Like, so we have some differences, like daddy. And then part word would be like where you hear part of the syllable. So like coffee. Sound prolongations a lot of times, and to me a lot of times those are similar to hesitations. So sound prolongations where you hear them do the sound, they kind of draw out the sound. So stop, or it's usually fricatives. You can draw out the sound because there's airflow there. So F is another one. TH is another one. And then you'll have other things like rate changes. So their flow of speech can be very disjointed. Secondary physical symptoms. So a lot of times with blocks, you'll see the other physical symptoms, and that's they'll avoid eye contact. They won't look at you. They'll make maybe a face, maybe close their eyes. You'll see sometimes other body parts move. I had one person I worked with a long time ago. She did this thing with her finger, and I think she used it as a strategy at one time. And that clearly, I don't think it worked for her. But she would she would try to say her words. She had really bad blocks, and then she would always, her finger would come up to try to help her get the word out. So definitely you'll see sometimes like extremities, something they might do with their hands. So the environment. So what we want to say too, for whatever reason, stuttering seems to have a lot of shame, a lot of anxiety, a lot of low self-esteem related to it, more so than other speech and language disorders. The nature of it. So if you look at this, I like this one because it kind of shows you kind of some of these core, and then kind of what happens afterwards. So you'll see all the effects of a core stuttering episode, what can happen. So it's kind of like that iceberg picture, but you'll see that a lot in stuttering also. Here's the next one. There's that fear and avoidance for some of these behaviors. And so it's, for me, my focus is usually, hey, no one's 100% fluent. We all have issues sometimes where we stutter. How do we make it impact us less? How can we work through that and move on? Sometimes it gets built up as, such a big thing. And a lot of times, hey, we all stutter at some point. So that's kind of why I am more of a stuttering modification person versus a fluency shaping. So a lot of times in therapy, what do? So we identify what the stutter looks like. So what does their stuttering episode consist of usually? Here are the 3 stuttering behaviors we see this person do. Okay, what are some strategies to try to reduce that? And that's where sometimes you'll see extrinsic factors come into play. Are they motivated to just move on? Like this kid, I think, this one I told you where he's just like, look, this is how my family is. My dad does this. My brother does this. Like, I'm not real worried about this. Like, I don't want to spend an hour a week working on this. This is just who we are. So he was already, his extrinsic was, he lived in an environment where it was accepted. It wasn't a big deal. Like maybe other people were putting that on him. And so we had lots of discussions about that. I'm like, okay, his motivation was, I wouldn't say he was really motivated to make himself more fluent, because it didn't bother him. So it wasn't a factor for him. Whereas other people might be more motivated to get a little bit more out of therapy. So And really what we're trying to do is kind of that control piece. So we're trying to kind of change the, sometimes I stutter and I can help control and reduce it when it happens. So yeah, stuttering modification, here's the strengths and weaknesses. So some of the weaknesses stuttering modification is its willingness to discuss stuttering experiences. So some people aren't ready. Some people might not have the cognitive skills to talk about it. And a lot of times it's not really appropriate at the beginning stages of stuttering. So, but the strengths of it focuses on the individual, encourages their control, and just awareness of when they occur and how they're common. It's okay that they occur. So those are some things that I really like. Van Riper, if you ever look up anything from him, he's kind of one of those pioneers in speech pathology. So a lot of cool things with that we still use today regarding Van Riper. So the vocabulary, let's review this too, because I think it gets, again, speech, we like a million words to mean the same thing. So blocks is a stuttering, it's a stuttering behavior. So that's where there's like minimal airflow. It's like they're stuck. You usually start seeing the tension, the tightness too in their mouth. It's like there's no voicing. A prolongation. And prolongation can be a stuttering episode, and also can be a strategy to be more fluent. So prolongation is where we kind of draw out a sound. So I don't know if you've ever listened to anybody where they draw out maybe like a vowel sound or a certain sound. So that's where, like that stop or stop, you kind of hear that sound. And a lot of times what we do is we use a prolongation in the vowel, especially for an ending that we know might be difficult. So it can be a stuttering episode, but it also can be a strategy to help be more fluent, just FYI. And then disfluency, and you'll see them written a couple different ways too. That means the stuttering episode. That means when they have the stuttering event, it's a disfluent occurrence. Part word repetition, so maybe kind of that syllable. You'll see part word repetition. You'll see either like that consonant and vowel part, or actually a whole syllable. And sometimes you'll see syllable repetitions. Secondary characteristics. So when we're looking at some of these secondary characteristics, that's where we see those physical signs. Tightness in the mouth, tightness in the jaw. Maybe they do something with their shoulders, something along that line. And definitely those secondary characteristics, we know stuttering, it's a little bit more on the severe level. And then the external factors that can impact stuttering. Intrinsic factors, what are they thinking on the inside? Then eye contact avoided, and word avoided. So a lot of times when they know they're gonna have a stuttering episode, you'll see like eyes, they'll do something, they'll either avert or not look at you, or look down or look away, or avoid a word they know they struggle to say. And then insertions. So insertions and interjections, those are the we all do them for the most part. But some are on the severe end, where we would say that's causing the speech to be disfluent. So yeah, like I said, and then I say it and then I start really thinking about it. So insertions can also be categorized as a disfluent component in speech, and we can work on that. So this week we have a fluency observation, fluency assessment, and then a read and review summary. So in our book, on chapter 10. There's some great things about it. It's a good overview and some of the treatment for it. So really look at chapter 10. There's some great information in addition to what's on our reading review. Any other questions? I like fluency. It's actually a disorder I like that maybe not other people like to treat. But it requires a lot of support from the client themselves. So you can feel it's not always as successful in the way that we want it to be, but it's hard. It's a harder disorder to treat. So any other questions? Stop the shares. So be sure to look at your book. The book has some great ideas. And like I said, some of those secondary characteristics are sometimes hard to pick up on. And for you guys as SLPAs, if you notice that somebody's doing something weird with their face, or I had a kid, he did this weird thing, like where he scrunched his nose. And that was kind of a strategy he used. So I didn't really notice the stuttering, or he was going to stutter. What I noticed was his facial stuff was distracting more so than the stuttering episode. So we had to work on some of those secondary characteristics for him. So you'll see some differences for many in any client you stutter who stutters that you're treating. You'll see different things occur for them, and sometimes it's hard to pick up on. So that's where your supervisor will be helpful. And if you're working with a client and maybe you're addressing receptive language or expressive language, and then you're seeing some of this fluency, definitely always call it to your supervisor's attention, because again, it might be developmental, but it might be something new that's occurring that we might need to address in therapy. Now that their language has improved, maybe their expressive language has dramatically increased, and now we're seeing this. We just didn't see it before because their language was limited. So hopefully they're just going through the developmental window of that. But that's something your supervisor needs to be alerted, especially with our group, our young developmental group, that always call it to your supervisor's attention, even if you think it's just developmental stuttering. So any other questions? The good part means you're doing your job and their expressive language is improving. We see that a lot. Great. No other questions? Alrighty, I appreciate you guys joining me, and I hope you guys have a good night.